There we go. Okay, wonderful. Let's thank our sponsors today. We have AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnologies, and Takeda Oncology. I'll also add a little note that if you hear dings in the background, it's because I haven't been able to figure out how to turn off like the notifications, and that's the sound it makes every time someone enters the meeting, which is great. We want as many people here as want to come, but if you hear that dinging in the background, that's what that is more people entering the meeting. As today is a unique presentation, I wanted to introduce you to all the doctors that will be presenting to us here today, even though not all of them are here live. Today we're going to hear from Dr. Leif Bergsagel, MD from the Mayo Clinic in Scottsdale, Arizona. He is among the top researchers in the world who study the molecular pathogenesis of multiple myeloma. His laboratory is focused on understanding the molecular events that lead to the development of MGUS and its progression to multiple myeloma. The research of Dr. Bergsagel and his colleagues has identified important subtypes of multiple myeloma that respond differently to treatment, are associated with different survival rates, and form the basis for a risk-adapted approach to therapy. Using insights gained from an understanding of the genetic events that lead to the development of multiple myeloma, Dr. Bergsagel's team have generated a mouse model of the disease. The model is being used to screen novel agents for their anti-myeloma activity. Dr. Bergsagel's team have cloned more than 35 translocation breakpoints and identified 5 frequent translocation partners that are present in almost 1/2 of patients with multiple myeloma. They are now working to identify and clone various translocation breakpoints in order to clarify their roles in development of multiple myeloma. Another focus is on the MYC oncogene that appears in some patients to cause the progression of MGUS to myeloma. As you can tell, he is a groundbreaking myeloma physician. His work is amazing. Prior to joining the faculty at the Mayo Clinic, Dr. Bergsagel was on the medical faculty of the University of Toronto and a medical staff fellow at the National Cancer Institute. He was a junior resident at the Stanford University Medical Center, completed his internship at Sunnybrook Medical Center, and received his MD from the University of Toronto. He is a member of the National Institutes of Health Basic Mechanisms of Cancer Therapeutics Study Section and the American Society for Clinical Investigations. His honors include lectureships at Ohio State University, Hammersmith Hospital in London, England, and the Daniel E. Bergsagel Visiting Professorship at the Ontario Cancer Institute in Canada. In 2009, he was honored with the Robert A. Kyle Mayo Clinic Distinguished Investigator Award. His father actually was one of the first physicians that worked on myeloma therapies and working towards a cure. We're going to hear more about that later today. It's absolutely fascinating. We also will hear from Dr. Matthew Fero, MD, FACP, and he's at the University of New Mexico Comprehensive Cancer Center in Albuquerque. He is a professor of medicine in the Division of Hematology and Oncology at the University of New Mexico Comprehensive Cancer Center. He leads the Hematology Clinical Working Group, which runs all of the myeloma clinical trials at UNM and throughout the state of New Mexico. In addition to his clinical interests in myeloma and bone marrow transplantation, Dr. Fero runs a research laboratory that studies the molecular mechanisms of development of I don't know how to pronounce some of these words, they're too big. Hematopoietic malignancies. I even practice and I still don't know how to say them. The preclinical study of novel therapeutic agents. A major focus of Dr. Fero's lab has been the interaction of cell cycle regulators and microRNA that go awry in organ tissues. The lab seeks to induce cell growth where it is needed to restore function to a damaged organ. He has developed the UNM's BMT program, the only FACT accredited program in New Mexico. Prior to joining the UNM faculty, Dr. Fero served as a BMT attending physician, performing all forms of that word. Hematopioidic.
Poetic. Hematopoietic.
Thanks, Dr. Lee. I knew you would help me. Stem cell transplantation and CAR T therapy at the Fred Hutchinson Cancer Research Center for 19 years. Additionally, he was associate professor at the University of Washington. He trained in internal medicine at the Mayo Graduate School of Medicine in Rochester, Minnesota, before completing a medical oncology fellowship at the University of Washington. Dr. Fero received his MD at the University of California, Irvine, and bachelor's degree in microbiology at the University of California, Berkeley. Dr. Sarah Lee is a hematologist-oncologist who specializes in the care of patients with plasma cell disorders. Before joining SCCA, she completed a fellowship in the hematology-oncology at the Cleveland Clinic. Her background also includes experience in researching novel therapies for multiple myeloma, amyloidosis, and other plasma cell disorders. What drew her to SCAA was the opportunity to participate in clinical research and to embrace a collaborative approach to medicine. Although she's relatively new to the field, she's extremely passionate and very knowledgeable thanks to her extensive research and practice. And she's also very kind as she helps me learn how to pronounce these big words. So let's begin. I want to start by watching the start of Dr. Bergsagel's presentation with you. And although we won't be able to watch it all, I highly recommend you to tune into his entire presentation once you receive that link in your follow-up email. So let's hear from Dr. Bergsagel. And I will share that tab.
My name is Leif Bergsagel. I'm at the Mayo Clinic in Arizona, and it's a pleasure to speak with you this morning. And I hope that we have some fun this morning. I'm going to give you a history of myeloma. It's not just 50 years. I'm going to give you about 70 years of history of multiple myeloma in a few short minutes. And I think it's helpful because when you're familiar with the history, I think you'll see there's a lot of reason for hope. And the story really starts with my father, who's shown in this slide here, who got his first job at the MD Anderson in Houston, Texas in 1955. And one of the first papers my father published was this one in 1962. And if you look at the title, what he's proposed here is a plan of study. And that's very unusual in the medical literature, to write a paper about what you propose to do as opposed to what you've done. But basically the premise was that a spontaneous regression of myeloma had basically never been reported. And most drugs that they were trying to treat patients with were really not effective in more than 20% of patients. And they expected most drugs that they tried would be ineffective. So he basically proposed to treat 11 patients with a drug. And if it didn't work, they would discard it and move on to the next drug. And this was a way of doing a very rapid clinical trial where they could test a number of agents and try and find some drug that would be active in patients with multiple myeloma. And the fourth paper in this series of papers that he's published, they use this drug, L-phenylalanine mustard. Many of you may know that drug. If you had a stem cell transplant for multiple myeloma, it almost certainly used melphalan. And this is one of the first patients that was ever treated with that drug. And what this figure is showing you is what's called a serum protein electrophoresis. And the spike that you see on the left is the M spike. And with treatment, that M spike goes away. And so that M spike shouldn't be there. And so you may have seen this in your own records. And our goal is to get rid of it. So this was an amazing result at the time to completely get rid of that M spike. And what was even more remarkable was that a year later, the M spike was still gone. So here was a treatment that could, get rid of the disease. And it turned out that the man in whom this was done was a truck driver in Texas. And shortly after that electrophoresis there in September 1960, he lived in Texas, and so not surprisingly, he got into a gunfight and he was killed. My father approached his widow and asked her if he could perform an autopsy on this man because he couldn't find any myeloma in this man when he was alive, and he wanted to look as extensively as he could for any evidence of myeloma. And at autopsy, the widow agreed, and at autopsy, he couldn't find any evidence of myeloma. So at the time, my father thought he was this close to curing the disease. And he reported this in one of the major medical journals, the Houston Chronicle. They wrote an article about this, fantastic new drug that seemed to be curing patients. And he also reported in another article which is more prestigious, Science, in 1965, about.
Okay, sorry about that. I need to keep my microphone unmuted. But I just wanted to summarize this next part because I think the majority of the interesting content or applicable content to you guys comes later. So what he's about to say is that another scientific paper was published by his father in 1965. And it showed that melphalan could drive down the M spike for prolonged periods of time in half of IgG kappa patients, but in none with IgG lambda. But later on, this study could not be reproducible, and it was refuted by other medical establishments. So although he thought he was this close to a cure, unfortunately, as we know, that is not the case. However, as we know, melphalan has become extremely wide used drug, especially in the use of stem cell transplants. So now we're going to fast forward a little bit until we get to the part where he talks about the next major breakthrough in the multiple myeloma field. He's going to be showing you a graph that shows the longevity of multiple myeloma patients and where we were and where we're going to be and where we could be due to these major breakthroughs. So let's take a look.
So to summarize then, about 50 years of myeloma history, and this was really the span of my father's career. The very first drug that was found to be active is related to dexamethasone. It's called a glucocorticoid, and I'm sure many of you, probably all of you, that are patients will have taken dexamethasone. And then shortly after that, in 1962, my father reported melphalan, and there's another drug that we often use called cyclophosphamide. And then pretty much for the rest of my father's career, there were no new active drugs identified. And if you look at that line and that curve and the improvement of the 5-year survival, it was just inching up at about 0.5% per year improvement. And if it continued on that trajectory, it would take 140 years before it would get up to 100%. And so my father at that time, when I was finishing my fellowship and starting my career in myeloma research, said, if you want to make a difference in the treatment of multiple myeloma, you need to have two things really. You need to have a better understanding of the biology of the disease, and you need to have better drugs. And the story I'll tell you now is how some of those things came. Well, I won't tell you too much about the biology, but I'll tell you about how we came to have better drugs. And some of you may have seen these articles that appeared in the press about 10 years ago. Celgene 2 widow who discovered Thalidomide. Go take a running jump. Lawmaker says drug maker Celgene stole her ID. Celgene, of course, is the company that makes Revlimid. And did Celgene steal this woman's idea? And if you look at this, it talks about a patient named Jacobson who contacted her doctor to suggest that he try Thalidomide. And so it turns out one of my patients saw this press and actually looked at the lawsuit and contacted me. Here's the lawsuit from Beth Jacobson against Celgene. But the reason my patient contacted me and told me about it was that I featured in this lawsuit. And it turns out in November 1997, I received a call in my laboratory. At the time I was in New York, from a desperate woman who's the wife of a patient, and asking me if I had any ideas of things that could be done for her husband. And I had just come back from a conference in Stockholm, where I'd heard Judah Folkman talking about inhibiting angiogenesis with a drug called thalidomide. And so I told her about this. I thought it sounded quite exciting. And I told her to call Dr. Folkman and to get on his clinical trial of thalidomide. And the story is really quite amazing, is that Dr. Folkman didn't take her calls. And so eventually, she called him at home on a Saturday night. And he was forced to take her call. And he agreed that, he thought it was reasonable to try thalidomide in her husband. But he was actually a pediatric thoracic surgeon, and he didn't treat people with multiple myeloma. So he told her, well, just have your doctor call me, and he can, get compassionate use of thalidomide. So she went to her husband's doctor, who is Dr. Bart Barlogi in Little Rock, Arkansas, and he scoffed at the idea. He thought it was crazy, but he was convinced enough to speak to Dr. Folkman, who convinced him. And her husband turned out to be the very first patient to be treated with thalidomide for multiple myeloma in the modern era. And unfortunately, he didn't respond. But as they had some leftover drug from treating him, the patient in the room next to him said, well, why don't I give it a shot? And the second patient to be treated, the disease disappeared completely. And that is how thalidomide came to be used. And we don't use quite so much thalidomide anymore, but we use Revlimid and Pomalyst, which are related. And the other drug that really changed things is a drug called Velcade. And it inhibits something called the proteasome, which was identified by Dr. Marian Orlowski. And his son, Dr. Robert Orlowski, was the first physician to treat a myeloma patient with a proteasome inhibitor, Velcade, and also see dramatic responses. And so with those two discoveries, the shape of this curve changed dramatically. And what you can see is that instead of increasing at a rate of 0.5% per year, the rate of increase has now gone to 2% per year. And if we continue on this trajectory, you see that we'll be at 100% for patients diagnosed in the year 2030. And the drugs that really changed it was thalidomide and the related drugs, Revlimid or lenalidomide and pomalidomide or Pomalyst, all called IMiDs. And then the proteasome inhibitors, Velcade or bortezomib, carfilzomib or Kyprolis, and ixazomib or Ninlaro. And then more recently, the use of the antibody daratumumab or Darzalex, elotuzumab or Implicity have also made a big difference. And the question is, can we repeat what we did here today? If we quadruple the rate at which we're improving the 5-year survival, which we did here, and with the new drugs like venetoclax, the bispecific monoclonal antibodies, the CAR T cells, belantamab, which has just been improved, if we once again quadruple the rate at which the 5-year survival improves, then patients diagnosed now will have 100% 5-year survival. And I've just plotted out in a more precise form so that you can have a look. Whenever you're looking at survival curves, you have to look at people who were diagnosed back, 2012 here or 2009 here. And so you have to say, if someone is diagnosed in 2021, and we've continued on this trajectory, we haven't improved it, we just stay on the same one we've been on for years, then the 5-year survival rate for someone diagnosed today is about 74%. And same thing for 10-year survival, about 60%. So
Audrey, you're still muted.
Sorry. Thank you. So I think he pronounces it Dr. Bergsagel, so I think I've been pronouncing it wrong, but I hope you see through his presentation, he shows how far we've come since the beginning days of his father's career. And there's already an immeasurable amount of hope about life expectancy and quality of life than there was just 50 years ago. And as he showed on his graph, recent drug discoveries dramatically have changed survival rate, as he stated. The 5-year survival rate should reach 100% by the year 2030 for multiple myeloma patients. And if these new drug technologies and treatments and stuff that are coming out, if they're as successful as we think they will be, patients diagnosed now will have an automatic 100% guarantee that they have a 5-year survival rate. Now, how encouraging is that compared to long ago where they weren't even sure where to start with their myeloma treatments? So exciting to me. So now we're going to hear from Dr. Matthew Fero, and something that he explains that I thought would be beneficial for you is he kind of goes through the 3 steps of treatment, we'll call them. It's induction therapy, and then stem cell transplant, and then maintenance therapy. Now, not everybody will have a stem cell transplant. Not everybody will be on maintenance therapy, and he does explain that. But I wanted to show that to you. So we're going to jump over there, and we're going to watch his presentation.
This slide, I'm sorry, doesn't quite fit on my screen, is meant to show the timeline of therapies, and it's kind of color-coded to the class of therapies. The earlier treatments that Dr. Bergsagel mentioned was these alkylating chemotherapy agents that actually go in, damage the genetic material of DNAs, and induce a self-destruct mechanism. But it's pretty non-specific because any cell that's growing and dividing in the body will have that same kind of effect. However, it was found to be effective, and when done at high doses, it's even more effective. And that's basically the basis of an autologous stem cell transplant. Early on, transplants were done using the bone marrow of the patient, which is very, a lot of morbidity to go and have that harvested, especially if you're sick and have brittle bones. But later we learned that we can harvest stem cells from the peripheral blood. After giving the patient a growth factor shot, it turns out not only do the white blood cells increase, but stem cells go into the circulation, and we can collect them that way. And then, of course, around the year 2000, there was just a whole series of remarkable innovations in myeloma therapy with the development of the thalidomide, as we heard, and the proteasome inhibitors. Both of these interfere with protein turnover in the cells and alter the signaling pathways. And finally, antibody genes fuse to T cell receptors in a modified T lymphocyte. So it's a cellular-based immune therapy. And then a recent medication that's come out is exciting because it functions by a different mechanism, and that is selinexor, and it interferes with protein nuclear export. The reason why it's exciting that something has a new mechanism is that sometimes the resistance that we see to one drug carries over and also confers resistance to other drugs. So it's nice to have a medicine that works by a different mechanism. So for example, the alkylating agents work by a different mechanism than these proteins, these drugs involved with protein turnover. And so transplant is often beneficial even if these other therapies aren't working, and vice versa. So this is the same thing kind of listed in kind of a list format, the different classes of medicines and just naming them. So you probably, folks have seen many or all of these medications in their therapies. And as you can see, there are several drugs in the IMiD class of medicines, the proteasome inhibitors, and if one drug stops working, you sometimes can get benefit from the other one, but oftentimes it's not as long-lived. So it is nice to have treatments that work by different mechanisms. So one of the topics was what is standard therapy for myeloma? And that's a little bit difficult to say because there's a larger and larger smorgasbord of options for myeloma therapy. But in the US, it's pretty standard in the majority of patients to use a triple therapy for the initial treatment of myeloma patients. And a common regimen, which I'll show you a little bit more information about, is a combination of Velcade, Revlimid, and dexamethasone, or we might call that VRD. And but there are other triple combinations. And most of these have the similar classes of medicines in them, so they're slightly just different flavors of the same thing. The Cyborg is slightly different because there's an alkylating agent in this one. After the initial treatment period, if the disease has achieved a good response, then you may decrease the level of therapy and do what we call maintenance therapy. And I'm going to talk a little bit about the pros and cons of these treatments and what we know and what we don't really know. One of the things that we first think about when we're considering treatment also, though, is how sick is the patient and how able are they to withstand these treatments. You know, patients can get myeloma at all different ages and they can have all different kinds of health status. One consideration that we think about is are we thinking that this person might benefit from a transplant later on? And or are we thinking that they're not interested or it wouldn't really be suitable? And actually, you may have more treatment options if you're not a transplant candidate because some of these medicines reduce your ability to collect stem cells, and you may not want to do them as long or upfront if you are thinking of doing a transplant. On the other hand, if you're not very fit, then doing many drugs all at the same time may also be too toxic, as Dr. Bergsagel mentioned. This is actually real data from a study comparing the combination of 2 drugs, Velcade and dexamethasone, versus 3 drugs, Velcade, Revlimid, and dexamethasone. And this primary endpoint was just how many people disease responded. And the definitions of the response, so you have to kind of set some kind of criteria for putting them into categories. So the PR or partial response is if the markers in the blood and urine went down by more than 50%. So there was only 10 to 50% of what you started with. And this is how many people achieved a partial response. There was also some patients who had over 90% of their markers go down. So there was less than 10% of what they started with. And that's here, the very good partial response. And then, the holy grail is to get a complete response where all the markers are completely not detectable. And that's what's seen at the bottom. But if you add all of this up, patients who had at least a 50% reduction with the triple drug regimen, you see over 80% of patients have achieved at least a 50% reduction in the burden of disease. And about 16% of patients or more have had a complete response where it's actually not detectable at all. So, all of this is really just numbers on paper. What does that really mean for translating to how somebody's doing? Well, it turns out that those responses really do have a significant impact on the experience the patient has. On the left is how long the disease is in remission according to which category of response you saw in the patients. So the patients whose disease kind of stayed the same, didn't go down by 50%, you can see that it was a much shorter time, less than 2 years before their disease started progressing again. On the other hand, if you had more than 90% reduction, a very good partial response or complete response where you can't see it at all, these folks went about 4 years before you saw their disease progress again. The same kind of thing actually was seen with the life expectancy of the patients. That's shown over here. Everything shifted to the right, but you can see that the disease getting in remission was a predictor for how long somebody lived as well. Now, one of the concepts I think is important to understand that even physicians sometimes forget is that what this largely represents is the variations in the biology of individual patients' disease. So some folks just have more gene mutations, or they have gene mutations in the myeloma that makes it harder to treat. And this difference in response isn't so much having to do necessarily on how long you did the therapy or the particular combination you chose. It's just some disease is slower growing, or some disease just melts away much easier in some patients versus others. It's still important to know, but it's not necessarily, it doesn't necessarily guide you too much in your treatment.
All right. So I hope you thought that was as interesting as I thought it was. Dr. Fero goes on to explain the pros and cons of combination versus sequential therapy. So in a nutshell, combination therapy uses more therapies simultaneously. It generally has higher response rates, longer responses, but as you would guess, it has significantly more side effects because you're increasing the amount of chemo, or as Dr. Fero states it, poison in your body, therefore you're going to have more side effects. Sequential therapy means that you're using one treatment after another. And while that has lower response rates, it has fewer side effects and it also is less expensive. So then Dr. Fero begins to talk about stem cell transplants. So we're going to fast forward to that part where he is discussing the actual process of the stem cell transplant, as well as considerations to determine if a stem cell transplant is appropriate for you. He's also later going to discuss maintenance therapy, specifically Revlimid maintenance therapy. So let's hear a little bit more from him.
So what about stem cell transplant? Stem cell transplant is a way to just give more melphalan chemotherapy. The oldest drug we have in myeloma is most effective if it's given in a high dose. But if it's given in a high dose, it knocks out the normal blood cells as well. And a way around that is just to get the bone marrow from a patient and give it back to them after the chemotherapy. So we do this from the peripheral blood, as shown down here on the left, using an apheresis machine. So it's a pretty benign procedure, much more benign than if you harvest it from the bone marrow in the old days. Just for completion's sake, I'm showing that stem cells can be obtained from umbilical cord blood as well. That would be appropriate for a donor transplant or allogeneic, and I won't be talking about that right now. So collection of stem cells, in order to get enough stem cells in the blood, you have to give a growth factor shot for about 4 days, and then you can go onto an apheresis machine like I showed. And sometimes that'll get you enough stem cells in the blood where you can get enough for 1 or 2 transplants. But oftentimes we add this extra medicine, plerixafor, which pushes even more stem cells out into the blood. When you give the treatment, it's really just a single dose of melphalan that takes an hour or 2 to infuse. And then you have all the consequences to deal with because it's given in a high dose. The drug's out of your system a couple days later, so we infuse the stem cells back in just like a blood transfusion. And over the course of the next week, we see the blood counts go down. And then about 2 weeks later, we see them rebound and come back up again. But there's a lot of other side effects that go along with that. So for example, the next most sensitive organ is the GI tract. So patients really struggle with anorexia, diarrhea, nausea, and need a lot of supportive care during that time period. And because of that, the treatment isn't necessarily appropriate for everybody. You have to be pretty fit to be able to do it. And so that's a careful conversation we need to have with all patients who might be interested. So is it right for you? I think the things to think about are your age. There's not a hard cutoff at age 70, but we're often reducing the dose of the drugs because the side effects are harder to deal with, and then you might not get as much benefit from it. If you're over age 80, I think is generally not even worthwhile considering. And in your 70s, I think if you're on the lower end of that and you're super fit, it may be more appropriate. You know, if you're 40 years old and you have myeloma, then the chances are you're going to run out of treatment options. So I would definitely recommend it in younger patients because you really should take advantage of everything that's out there. The other question is, how fit are you? I ask my patients, are they able to walk a mile a day? Not necessarily in one, straight stretch, but it's just it's a pretty good indicator of whether your medical condition or the myeloma itself has made you too sick to be able to really withstand that. And the other aspect of that is, if you're not in good shape, it takes longer to rebound. So you're more likely to get benefit and get back to your normal lifestyle quicker if you're in better shape. Is the disease in remission? Well, it's best to do a transplant when the disease is under good control, because you'll get a longer duration of benefit, but also it's hard to do intensive therapies afterwards. So you want to have a time period where you don't have to do very intensive treatment after a transplant. There's a big time commitment. You shouldn't have other serious health problems. And then you have to think about the side effects that we talked about. The benefit, it doesn't cure the disease. It on the median time of remission is about 3 years if you go into transplant with the disease under good control. If it's not under good control, then it's going to be less than that. The overall impact on survival is pretty minimal, as we saw, but old randomized studies showed 0 to 1 year of improved overall survival in transplant patients. It's relatively cost effective when you think of the outrageous costs of other myeloma therapies. So it makes sense to do cost-effective therapies up front. And it's a different mechanism, as I said, the alkylating agents versus the other sort of newer treatments. The complication rate nowadays is pretty low because we know how to support these patients and to select patients who are reasonably healthy. But infections are the biggest risk that can happen when the blood counts are low. And GI side effects add to that infection risk, and also are, add to the morbidity and the discomfort of patients. So what about Revlimid maintenance? I think I'm going a little bit late here, so I'll try to be brief. Or maintenance therapy is when you do a single drug or drugs at a reduced dose after getting the disease in remission, with the idea of trying to improve the overall benefit to the patient. There have been a variety of randomized studies looking at maintenance therapy, and this is one looking at Revlimid maintenance. And on the left, you see the duration of time that people's disease stayed in remission if they took low-dose Revlimid as maintenance after their primary induction therapy. So you can see they stayed in remission longer. On the right, what you see is that the impact on the survival, the life expectancy of the patient with the Revlimid maintenance was pretty minimal. And so you could argue what the benefit of this is. This is mostly a number on paper. Your markers on your lab results look better longer. If you see the progression, you probably have to go back on therapy. But if you were not on Revlimid maintenance, whereas if you're on Revlimid maintenance, you may not have to go on to such an intensive therapy as long. So whether that's worth it, I think, is arguable. It's harder to make the argument that you're going to live longer and that it should be strongly recommended. However, it is often a standard, and it is the same kind of benefit with progression-free survival, or this time that your remission is seen after transplant, as well as after other induction therapies. So this is kind of the dilemma. Do you do a maintenance therapy? Do you do an induction therapy and then a maintenance? And the clinical trials often compare these two things. But why is it that you don't actually live longer? If it keeps your disease in remission longer, then why wouldn't the life expectancy be longer? And the simple reason is that in reality, this is not what happens. The people who were not on maintenance therapy, they got their induction. They did not get maintenance, but when their disease came back, then they could get the Revlimid off study. So it's not that you can't get the drug. It's the question more is the timing of the drug. And it turns out that you may get just as much benefit by doing that maintenance drug at a later time versus if you did it at an earlier time. And so the question that we often don't address in our clinical trials is the timing and sequencing of drugs, as opposed to whether or not the drug has some kind of benefit. That's my last slide. I hope I didn't go over time too much. I hope that we address kind of the concepts here as well as some of the details. Thank you very much.
Yeah, I know, it's fantastic. So thank you so much. That's a lot to cover in a very short period of time. And I think for newly diagnosed patients, it's okay if you feel overwhelmed with all the content that you're going to be seeing today. It's like a fire hose. And it really takes some time to kind of get used to what are the drug classes. And you did a really nice job going through the different drug classes and transplant. And I like how you focused on just stay fit, no matter what stage of myeloma you have. I know some patients have more bone damage than others, but stay as fit as you possibly can because it opens up opportunities for you.
Okay, so let's talk questions. As Jenny said, I wanted to show you that last part, even though it was kind of a little bit different or maybe semi-awkward, but Jenny, who is the founder of the Myeloma Crowd and of Health Tree Foundation, as she said, this is a fire hose of information, and it's okay if you feel overwhelmed with the information that we are sharing today. That's completely understandable and normal, and that's why we have Dr. Sarah Lee here today to answer your questions. I want to remind you there are no dumb questions. We are growing a community here, and this is such a new topic and such an overwhelming topic, so please ask your question. Keep in mind that our session next month for this same chapter is going to be on stem cell transplants. That's not to say that you can't ask any stem cell transplant related questions, but we will be able to better answer those questions next month as we have an entire session dedicated to this topic. We have a system for asking questions, and it involves using the raise hand feature. It should be located at the bottom of your screen, whether you're using a computer or a phone. It's the little hand icon. If you have a question, please click that button. Our system keeps track of the order those questions were asked in. Diana from our team will be navigating whose turn it is to speak. When Diana calls on you, please unmute your microphone, turn on your camera only if you feel comfortable, and ask your question. Dr. Lee will be answering any questions that you have. So let's get started. We did have one question come in just to launch this question and answer session. We had a question come in via email about what are the latest pros and cons of the use of Zometa? So Dr. Lee is going to answer that, and if you have questions for her, please use that raise hand feature and we'll be able to get started.
So before I answer, I just want to thank the Myeloma Crowd and Audrey for organizing this event. And just like she said, just like Jenny said in the recording, and it's something that I tell all patients when I see them for the first time who are newly diagnosed, that it is a lot of information that we're throwing at you at once. And on top of that, you're dealing with the fact that you've just been told you have this blood cancer. And so I'm sure emotionally and mentally, you're just going through so much and, you know, trying to figure out what am I supposed to do next. So it's very common to just feel overwhelmed. So I think it's really important to, you know, get plugged into a group like this and find a, you know, myeloma specialist, a place that really focuses on it to get some information first, and a trustworthy place where you can trust the information that's coming, because it's going to take time for you to educate yourself and to really be able to digest this information for yourself and be able to know what questions to ask. So you want to be able to go to a place that's reputable where you can at least take what they're saying at face value while you're trying to play catch up and get, you know, caught up with everything that's been going on. But so I'll just say that as a plug. But certainly when we're talking about bone modifying agents or things like Zometa, you might also be on heard things like denosumab or pamidronate. These are all bone modifying or bone strengthening agents that are really important in treatment for myeloma. So we, you know, in the talks that Dr. Bergsagel and Dr. Fero gave, they talked about kind of the anti-myeloma actual, you know, chemotherapy drugs that we give. These bone modifying agents, when I talk to patients, I see these are just as important anti-myeloma treatment drugs that you should be on as part of your induction or frontline treatment. You know, one of the things we worry about most with myeloma is that it can affect the bones. And so this helps kind of strengthen the bones, decreases the breakdown of the bone, you know, lytic lesions that can happen. It can kind of help start healing some of those lytic lesions. There's three main ones that you can choose. Like we said, Zometa was the question that came up, but denosumab and pamidramate. Denosumab is generally used for patients who have really bad renal compromise when they're starting out. So if you have, myeloma in the kidneys and your kidney function's already compromised, and that's probably a drug that they would choose for that. Otherwise, Zometa and pamidramate is kind of the more go-to agents, but they all help in strengthening the bones, and something that you should be on for at least a year. Generally, we do for 2 years at start of diagnosis, and then depending on, if you have further disease involvement or whatever, that's a conversation you have first with your doctor, but at least 2 years of bone modifying agents are recommended. I will say the main side effect that we worry about is osteonecrosis of the jaw, or that's kind of deadening of the bone tissue in the jaw. And though it's pretty uncommon and rare, if it does happen, it can be quite significant. And so one of the things that we recommend is that if you haven't in the, last 6 months or year before starting, is to go see a dentist, have them look and examine, make sure there's not any ongoing dental issues that need to be taken care of, any infections that need to be taken care of, cavities, things like that. If you get an all clear from the dentist that the teeth are healthy and looking good, then we would then proceed with starting that as part of your induction treatment.
Okay, so thank you all for coming. My name is Diana, and we will start with the questions. Laura Russell, you can unmute yourself and ask your question.
So if you're not sure how, there you go.
Can you hear me okay? There you go.
Yep.
So I guess my question is, I have gone through induction treatment as well as a stem cell transplant in September, and starting maintenance therapy because I have a deletion 17p portion to my myeloma. I had a drug eruption that they believe is from Revlimid. Is there any other path for me for maintenance treatment? Should it turn out that my body cannot accept the Revlimid moving forward?
Yeah, so after transplant, Revlimid is the first drug that was approved for maintenance therapy, and generally what we will go to, partly because it's also something that's easy to take. It's a pill a day, you take it home, you don't have to come back and forth for. But proteasome inhibitor, so Velcade, which is something that everyone usually gets with their upfront treatment as well. That's approved, as well as Ninlara, which is the oral version of that for maintenance therapy. One of the things that we, when you have some high risk mutations or features, chromosome mutations, things like deletion 17p, that might make us a little bit more concerned that, the disease may come back quicker or act more aggressive. Sometimes the maintenance may actually be 2 drugs, so both an IMiD and a proteasome inhibitor. So if you are having adverse effects to the lenalidomide, then I think it's very reasonable to then talk to your physician about maybe doing Velcade as a maintenance. And then if you're able to, if that's the only one you're able to take, then doing single agent Velcade. But if you're able to do Revlimid too, then potentially doing both of those drugs as a maintenance would be a reasonable option with the deletion 17p.
Okay, thank you. Yeah, we are doing dual maintenance, so we'll find out in a couple of weeks how I respond when we start maintenance back up again.
Good luck.
Thank you.
Well, thank you, Lara, for your question. Now it's turn for Marlene. Marlene Falkingham. You can unmute your microphone.
If you're not sure how to unmute your microphone, you can move your cursor to the bottom of your screen, or you can move your finger to the bottom of the screen if you're on the phone, and there should be a white bar that pops up with a microphone icon. If you click that, you can unmute yourself. But if we're not hearing from her, let's move on to the next one.
Okay. Okay, so next we have someone who logged in as Turning Point Center. Should I go to the next one? Okay. We have Elise Banducci.
Hi, this is actually Elise's husband. My name is David. Thank you for having this webinar. I actually have two questions. You should feel free to answer either or both. It wasn't clear to me what the actual information or data are on the effectiveness of Revlimid as a maintenance drug. So in the presentation, the doctor kind of suggested that if you just look at the numbers on paper, there wasn't much effectiveness, but then he went on to say that the reason for that may be that people don't take it initially, but then they do take it later on. So do we know what the difference is in terms of survival and maybe also quality of life for people who don't do it at all versus people who do it at some point? That's the first question. The other question is, can you say anything about daratumumab as a maintenance therapy or an induction therapy? Thanks very much.
Sure. So with maintenance Revlimid, I think in terms of overall survival, it when we talk about, I think you have to do it with the idea of transplant too. So it's transplant and maintenance therapy. So when you're looking at that, I think what we see is overall survival, like Dr. Fero was mentioning, tends to be about the same in patients who who don't go right away into doing transplant with maintenance versus patients who might, just get their induction treatment and maybe do some maintenance there and then get transplant in the first relapse setting, or in patients who get the transplant and then don't do maintenance but then start Revlimid once counts seem to go increase. So the benefit seems to be more in potentially progression-free survival. So the amount of time potentially that you're on the treatment without having disease become active seems to be better when patients who who do maintenance, who get the transplant. The other thing is that it could potentially lead to more stringent complete responses, or so for example, if you had you got your induction treatment and you had a very good partial response, you went for your transplant. Afterwards, you still had maybe a very good partial response, but then you start maintenance, and that's what allows you to go into complete response. What Dr. Fero and I think Dr. Bergsagel both showed was, it's the depth of response does seem to make a difference in terms of, progression-free survival and potentially overall survival. And one of the things that we're starting to look at also now is MRD testing, or minimal residual disease testing. And we see that people who have really as deep of response as you can get seem to do better in the long run, certainly progression-free survival, and we're getting data to see if that translates to overall survival. So I think that would be potentially one argument for, doing the maintenance treatment after your transplant, even if potentially, especially in those patients who maybe didn't get a complete response after transplant. I don't know if that answers that part or not. I can circle back if you need more clarification.
That's helpful. Thank you.
Okay, and then I think in terms of daratumumab for maintenance and for upfront. So there are clinical trials ongoing now looking at daratumumab for maintenance. So we don't have an answer for that, but certainly hopefully soon. In terms of upfront treatment, daratumumab is approved in patients for upfront treatment or frontline, the first treatment you're getting induction treatment. There's all these different terms for that. In patients who are not transplant eligible. So there are some combinations that are approved in that setting. There are studies, there's one trial, and we talked about at our big hematology meeting in December, looking at daratumumab in addition to the triplet backbone of Velcade, Revlimid, dexamethasone in patients who are transplant eligible, who are going to get transplant kind of upfront. And it's really exciting data. It seems like patients who have that 4-drug combination, there's a greater number of people who go into stringent CR, so basically all your markers are normal and your bone marrow is also normal. There's also a deeper response to people who have, or a higher number of people who get very good partial responses. So again, the depth of response does seem to matter. And so this is a 4-drug combination that seems to get more people into, higher response rates, and hopefully that will translate to longer progression-free survival and overall survival. But in the transplant setting, it's still not approved yet. But we're, I think, with this new data, some patients are able to get 4 drugs. Some insurance companies are approving it now that we have this data out from that trial.
Okay, thank you. So now it's turn for Gina Murphy.
Hi. Thanks for having this webinar. I'm in Dublin, Ireland, so hi to everybody. I think my question's been partially answered already. It was in relation to Revlimid. I too had a bad response to that, developed a bad rash, and have put on sideboard. I've recovered well from my stem cell transplant, and my maintenance drug was pomalidomide. So unfortunately had a similar reaction to that as I did on the Revlimid, and I have been started on Velcade. So I suppose I'm just wondering, so I'm just a week into that. So I suppose I'm just wondering, is there any data there on, in comparison to being on Revlimid or pomalidomide, the responsiveness, even though, is it better or the same, considered the same as being on Revlimid?
So we don't have data to definitively say that, because that hasn't been necessarily looked at. I think what we can kind of extrapolate is that we know, no maintenance versus maintenance, potentially is potentially better in terms of progression-free survival. So if you're able to find something that you're able to do maintenance with, I think that's, I won't say ideal, but if you're trying to do maintenance, then at least finding something that you can tolerate is important. And then I think in general, we know that patients who, can't tolerate Revlimid, or who potentially are refractory to Revlimid or relapse from Revlimid, doing a drug like pomalidomide or Pomalyst can seem to sometimes overcome that. And so it could be a good alternative even in the maintenance setting. But I don't have data to definitively say it's going to be better. I certainly don't think it's going to be, I don't think it's any worse at all. And if you're able to tolerate it, I think that would be good. Yeah. And I will say some of the side effects, so going on that, since it's been a couple of people now who've brought it up. So Revlimid, one of the side effects that can happen is you can develop a rash from Revlimid. It can be anywhere in the first couple cycles. It could also be within, up until the, 5th cycle, 6th cycle. And so it is a conversation to have, because a little bit of rash, if you're able to tolerate, if it's, not spreading, if it's just some redness, you can take Benadryl or Claritin with it, and it seems to kind of keep things at bay and not spread too much, then it's not necessarily a drug we would stop right away just because you all of a sudden develop a rash. It would depend on how severe the rash is, how much of your body it's covering. There's different things we can try in terms of changing the dose. And like I said, other kind of antihistamines or Benadryl, things like that to try, and topical creams to try with it as well. So there are things that we can do to try to mitigate those side effects before actually stopping the drug and saying you can't take it at all.
Thank you.
Thank you. So now we have Cassie.
Hello, hi everybody.
Cassie, just 1 second. Cassie's going to be our last one just because we're running short on time, and I want to be respectful of your time. So Cassie will be the last one to ask a question today. Feel free to email me if you do have a question that wasn't answered, and we will do the best that we can to answer that question. So go ahead, Cassie. Sorry to interrupt you.
Hi, Dr. Lee. The primary question that I have is this whole question about progression-free survival versus quality of life. And I'm just wondering if you're aware of any studies that have been done, or any tracking that's been done on a comparison between, every time I hear the statistics on progression-free survival and the amount of time that it takes for those treatments to happen, like SCT, 0 to 1 on a SCT, and the impact of that, having a large impact on quality of life, and comparing the cost benefit basically of that treatment versus not doing it and having that time without managing all of the side effects of having that treatment. Are you aware of any studies that have been done about that, and just how we make these kinds of decisions about, crashing our immune system because of the treatment in order to prevent the disease versus being then more vulnerable to other things like COVID and other kinds of opportunistic infections?
Yeah, I think that's a great question, and certainly something that we are much more aware of now, and more recent trials are looking at quality of life questionnaires and what we call patient-reported outcomes, or PROs. So that's becoming a really important endpoint in a lot of our clinical trials, is incorporating that data to find out, okay, we can do 3 drugs, we can do 4 drugs, can we do 5 drugs? But what does that impact? Yes, it does impact potentially outcomes in terms of, or how your myeloma is reacting or responding, but what is the cost of that in terms of quality of life, symptoms, exactly what you're talking about, Cassie. So we are incorporating those kinds of endpoints now into our clinical trials. We are seeing the thing that's reassuring for us is that, and that's, I think why we're so hopeful, is that we have a lot of great agents for myeloma that are active, and that really patients are still able to have a good quality of life with. They're generally well tolerated. If their side effects, we're able to manage them. We are seeing that these combinations, even with patient-reported outcomes, that there is, a benefit. Their patients are reporting better quality of life measures with some of these treatments. So we are seeing that from a data perspective, and then just obviously when we talk to our patients. But it is something to balance out. I will tell patients when they're first diagnosed, we're hoping this is a 7 to 10, if not longer, years of treatment that you're on. And the degree of what I'm going to be asking you as a physician as I'm working with you is that it's going to change depending on how your disease is going. In the beginning, things are going to be a little bit more intense, and what we ask of you might be more. We're going to be on 3 drugs. Maybe you'll be on 4 drugs. The transplant, if you're young and fit, might be something that we ask you to do. But, after that, if you're on maintenance, and hopefully it's just, 1 drug or 2 drugs potentially, and maybe that'll be as easy as it is for, a few years. And then if disease comes back again, then maybe we'll do a little bit more of an intense treatment. But things will kind of ebb and flow, and there will be periods where hopefully, you're just taking a pill a day and not really thinking much else about it. But that's certainly something that we always think about because we're doing these combination treatments. What is your baseline activity level? What are you able to do? And making sure that you're still able to maintain that, or at least close enough to that with the treatments that we're doing, balancing that. That's very important for us to always consider.
Great, yeah. And then I know you wanted this to be the last question, and I see that Tom from Turning Point Center is back active, and I'm wondering if there's any chance that if he's able to turn his microphone back on, if he'd be able to ask the question that he had, because I know he has some immediate concerns. Would that be possible?
It's fine with me. If it's okay with you, Audrey, let me just shoot me.
Yeah, go ahead.
Turn on your speaker, Tom. It's at the bottom of your screen, the little microphone at the bottom of your screen. No, you don't want to answer the question or ask it? You're not seeing the speaker? Darn it. Oh, you can't hear? Yeah, we can't hear you, Tom.
You might be able to type it in too if you have that.
Yeah, if you'd like to type it into the chat, you're welcome to.
Hang on, he says. He's got his wife helping him. he's I think that was I'm giving up. Bye. Okay, yeah, he's giving up. Well, thank you so much, Dr. Leif, for your help with all of this. It's I know these meetings are extremely important for those of us who are dealing with this, and I really appreciate everything that Myeloma Crowd and Health 3 is doing, and your availability today was extremely helpful. Thank you.
Yeah, we appreciate it so much. And thank you all for your questions. Again, I'm so sorry we didn't get to all of you. I will be sending out email correspondence, sending this recording, sending the slides, things like that. So respond to that email if you had a question that didn't get answered. And let's talk and try to get you that that answer. Wow, that escaped me.
And
All right, just gonna.
Oh, sorry. I'll just say, especially if you're newly diagnosed, it's really important. And I think it's a lot easier now that everyone's kind of savvy to telehealth. But you can really get a consult with anybody, kind of anywhere in the country these days with telehealth options. So even if you're plugged in with your local oncologist and you feel like you have a great rapport, I think it doesn't ever hurt to get a second opinion, not just a consult and talk to someone who really, this is all they do. I respect all our local oncologists who treat so many patients and so many different cancers, but I spend every day, all day, focusing on patients with multiple myeloma and being up to date on the research of that and doing trials and really just focusing only on this disease. And so, it's important to really connect with someone in a big center, a cancer center that does that, so you can get the latest information, because things, might be different, year to year, month to month. And so getting that information, making sure you're on the right track, making sure you feel supported, that you've got all your questions answered, and then you feel empowered to go back to your local oncologist and work together and do treatment and do those things. I think it's, certainly it's not a dig on your local oncologist. I think they always appreciate it. We work very closely with our local oncologist. So, be an advocate for yourself and, get that second consult, talk to someone at a big center, get plugged in with Myeloma Crowd and get, a good support network going for you.
Yeah, thank you for that. I think it's so important, especially what you said, the multiple myeloma specialist will not replace your oncologist. They're going to be working with your oncologist. It's an addition to what you already have instead of replacing, because I know that's a fear, or not a fear, but a concern for some people. Let's finish out today just with a couple of announcements. So our next newly diagnosed myeloma patients meeting will be on March 18th, 2021 at 11 a.m. Mountain, 1 p.m. Eastern, which is also 10 a.m. Pacific and 12 p.m. Central. It's hard to know which time zones to include. We will have Barb Hansen, a guest speaker, share her experience with a stem cell transplant and answer any questions that you might have about the process. So that will all be about stem cell transplants. You might be interested in other events that we have upcoming in our myeloma community. Wednesday, the 24th of February, we will have our selinexor support group event. So selinexor was mentioned as one of the new drugs in the myeloma arsenal. If you are using selinexor as part of your treatment or have a loved one using selinexor, or you simply want to learn more about this groundbreaking drug, join our selinexor support group on next Wednesday. Next Thursday, we will have the launch of our African American myeloma chapter, and we will be discussing how to be your own best advocate. On the 2nd at 11 a.m. Tuesday, March 2nd at 11 a.m. Mountain, 1 p.m. Eastern will be a special presentation for veterans as a part of the Myeloma Financial Coach chapter. We will have a guest speaker who is a lawyer and veteran himself come share some benefits and programs that are available for the veteran population. Wednesday, March 3rd, this one's not listed, but I did want to mention it. It will be our Intermountain Myeloma Support Group. So if you are from Utah, Montana, Idaho, Colorado, Wyoming, or Nevada, you are welcome to join us. That's Wednesday, March 3rd at 11 a.m. Mountain. You'll be hearing from Dr. Sporoff as he discusses clinical trials at the Huntsman Medical Center in Salt Lake City, Utah. Wednesday, March 3rd at 5 p.m. is our Fitness for Myeloma chapter. They're hosting an event called How Fitness Saved My Life, the Jim Bond Story. And yes, his name is actually Jim Bond. He is the recipient of 4 stem cell transplants. And as you heard in the footage that we watched earlier today, that is almost, that is so rare. It is not heard.
Not normal.
Yeah, it's not normal. And he attributes the 4 stem cell transplants being able to receive all 4 because he is so fit and because of his fitness experiences. So you're going to want to listen to this, to make sure to tune in. He's an amazing speaker. You won't want to miss that event. That's Wednesday, March 3rd at 5 p.m. Mountain, 7 p.m. Eastern. The link to sign up for any of these events that I've mentioned is listed on the slide. I will include it as well as the slides in the follow-up email we're going to be sending along. This again will be 24 to 48 hours after the completion of this event. Special thanks to our community event sponsors, AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnologies, and Takeda Oncology. And a big thank you to you. Thank you so much for sharing this virtual time with us. I know we went a little bit over, but I really appreciated the content that was shared, the questions that were asked, and of course, Dr. Lee for spending this time with us. Thank you so much, and we hope that you have a good rest of your day. We'll see you later.
Bye. Thanks, everyone.
Thank you.